minutes, maybe 40, and then we'll go to like discussion and questions. So the floor is
Okay,
yours.
great. I'll aim for that. Thank you, Kelly and Sam and others for the invitation. Again, my name is Tomás León. I'm at the California Department of Public Health. Today, I've titled this talk CalCAT Past, Present, and Future, and I'll get more into what CalCAT is, but it's sort of more of a meta thinking about how California has used infectious disease modeling and public health response from the early days of COVID onward. And so I'll sort of do a brief history of that and then talk a little bit about CalCAT. And then I had a couple sort of points that I'm going to reflect on. And then again, it would be nice to hear from you all and some discussion if we have time for it. So just to contextualize, everything that I share in this talk is part of what our team has done. And so it's very much collaborative, as many of you are in intersecting and overlapping teams. And so our current team members are Hector, Lauren, Mugda, Natalie, Phoebe, and Sindhu. We have a fair number of alumni, and the photos from one of our ill-fated, I shouldn't say ill-fated, but one of our Microsoft Teams Secret Santa. So you end up with interesting and funny snapshots like this. But I'm grateful for everyone on the team in the past, the present, and the future, and they all contribute to this work. So a very brief summary of, and I'm going to just make sure, yeah, my mic is set up okay. A brief summary of what our team, how it's developed. So in summer 2020, the California COVID assessment tool, CalCAT, was officially launched. And this was done in collaboration with some people from the tech industry, Silicon Valley, who are supporting the state of California in building this tool. And it's our public-facing model aggregator. The naming has since transitioned to the California Communicable Diseases Assessment Tool to reflect that we've added influenza and have the potential to add different diseases too. The modeling team itself was founded at the California Department of Public Health in the same period. And I believe we're still the only US state modeling team. I think there's other states that do have modeling capacity, and they have modelers sort of embedded in different teams within their organizations. In winter 2020 here in California, we had our largest COVID wave, and we put in place a regional stay-at-home order for the state, which was driven largely by ICU capacity modeling. And so we were looking at projections around ICU capacity as a way to determine when the stay-at-home order would be in place and when it would be lifted. And I'll say a little bit more about that in a minute. Just to touch on some of the iterations and improvements over the years, in 2021, we began adding our own internally developed COVID-19 models. Previously, we had scraped a lot of models from the groups that you're probably familiar with, a lot of academic groups, and some individuals and websites were also producing their own models. And we also started doing internal scenario modeling around NPIs and VE, sort of before we got more formally engaged with the Scenario Modeling Hub. In 2022, we started doing SARS-CoV-2 variant nowcasting, and we added influenza forecasting and scenario modeling. We also use modeling as part of our Mpox response. That was largely Natalie and our team. Not a lot of that has made that into the public domain, but I just want to mention it just to point out that, there were modelers sort of trying to build on what we had developed during COVID to be a part of other public health responses. In 2023, we started looking at combined respiratory burden, so forecasts and scenarios of COVID and flu together. We're now thinking about it with RSV as well, but it's complicated by data feeds, which again is something I'll talk about more. We also saw the end of the public health emergencies here in the United States at the federal level and in California at the state level. And this year, we're really working on diversifying our infectious disease modeling portfolio and working on other diseases and with other CDPH programs. And just to say, CDPH is our shorthand for California Department of Public Health. So that's how I'll be using it. CalCAT, as I mentioned, is a model aggregator. It's not a hub. We are not requiring standard submission formats to be on CalCAT. What rather is something sort of more organic and freewheeling, developed in the early days to sort of pick up all the nowcast, forecasts, and scenario models relevant to California. And so we presented at the state, regional, and county levels. It's a tool that we developed continuously throughout COVID-19, and we work closely with our local health jurisdictions. And so for those who are not familiar with that term, in the US, that largely means counties, but in our case, there's a few cities who are also their own local health jurisdiction. And we've iterated with them to add new features and make the tool more usable. The data is downloadable for use, and we try to provide as much technical documentation as possible. And while we're not Facebook or Google, we have had over 100,000 unique users, and while it used to be thousands of users a day, we still see hundreds of users potentially. And in what's potentially a metaphor for other things, CalCAT is down this morning for the first time in perhaps forever. So normally I would link it to you, but I might have to do that later on. So we'll get back to that. It's sort of an interesting anecdote that those of you who worked with IT departments are probably aware of similar situations. So instead of a live demo, I'll show you some screenshots from the past just to point out a little bit of what CalCAT has. This is our effective page. You'll notice that we show the median ensemble, and as you all know, there's been a lot of work on trying to improve past the median ensemble, and it's something that we worked on too. We didn't get much past the median, although I'm aware there's some good recent papers that suggest other methods, so we're always interested in ensembling. You'll see a host of individual models. Some of the names you'll recognize, some of them are methodologies, some of them are institutions. So a mix of internal and external. We try to highlight the latest estimate in a range. And importantly, I'm showing here statewide estimates, but really, I think one of the take-home messages is California is in a unique situation in that we're a very large state and we have many counties, and all the counties want to see their estimates. And so California state level estimates are not always particularly useful to our individual counties. So data sources that we've used for nowcasting, again, should be familiar. Cases, both confirmed and probable in both. And these are no longer publicly available as of, I think, December 2023 at the California state level. I forget when CDC started sunsetting some of the case data, and other states did it long before, but it's been deprioritized for reasons that I think you all are familiar with. Test positivity was used by some of our external collaborators. That was sort of sporadically publicly available, and some of them got it through data use agreements that, again, I'll mention again later. Hospitalizations, for those of you who work in the US, you know that one of our main hospitalization data sources, NHSN, is planning to become optional and therefore probably not super useful starting in May of this year. And so that's something we're planning around. And then wastewater surveillance. And so we've been calculating and showing a wastewater-based RT since July 2023. I know CDC, CFA has made great strides in this. There's some other academic groups that have done so as well. And so that's sort of a promising area of development in the nowcasting space as we see it. To touch on a couple other sort of CalCAT snapshots and use cases, I already mentioned the ICU projections. And so this is from December 2020. And, again, I'll be interested in the discussion part to hear your own stories, but, this was a sort of an early effort, I would say, and it was sort of an interesting case of models being used for clear policy implications as opposed to other cases where it might have been more subtle and people might have looked at model results and then made decisions. But this one was pretty tied to and influenced by actual ICU projections, and I can talk more about that if people want. Now, I think after the fact, like there's clear pros and cons to that. I think having the off-ramp, especially tied to modeling projections, is pretty tricky because as metrics were improving, if the models were missing sort of that downturn quickly enough, a lot of our counties and regions felt like their situation had improved and the model did not reflect that. And so they should not be subject to the stay-at-home order, even if the projection suggested that things were still not improved enough. And so I think using models directly for policy has a lot of pitfalls. I think there's opportunities, but I don't want to oversell it like this was a total success story. It was something that we learned from. Scenario modeling, probably everyone is somewhat familiar with this, but the US scenario modeling hubs, and I know there's several in Europe and elsewhere, they're pretty advanced now. I think they do their job really well. I think that, again, the thing I'll sort of point out is that for California, what we really wanted is county level scenario modeling results. And so these hubs tend to produce results at the state level. And so for us, we had to go directly to some of our academic partners and ask them to produce county level scenario modeling results, because that's what our local health jurisdictions wanted. And so this is a state level screenshot, but you'll notice there's sort of a mix of, it's not necessarily well labeled, but some of from the hub itself, and then a couple from sort of different academic groups that were producing results. I mentioned the variant proportion nowcast that is on CalCAT when CalCAT's functioning. It's been there since 2022, and we produce it in consultation with our genomic epi team. And it's an ensemble of 3 approaches when they work: the logistic proportion model, multinomial spline, what we call a simple growth model, which is sort of a fancy spreadsheet model. And as you can see, and probably you all are familiar with, the Omicron subvariant situation has been a little bit more complicated than the earlier days of the Alpha to Delta to Omicron transition. But it's something we still maintain, has some similarities with the CDC nowcast, but it's different in other ways. And going forward, I think data availability is going to be a real challenge, especially when we try to produce it also at the regional level. And there are some regions in California that don't have a lot of sequencing happening. And so sometimes we have to censor or drop results. But really, again, I think one of the goals in this is to produce sub-state level results for California public health agencies. Flu forecasting and scenario modeling, again, we've contributed since fall 2022. That's mostly Lauren White on our team. She's been contributing California results to FluSite, which is sort of the flu forecasting effort in the US, also to the flu scenario modeling hub for the last couple of years. Again, we're not able to produce it for all counties just because of small numbers compared with COVID, but we produce it for as many as possible. And we also do so at the regional level, which is an aggregation of counties into usually five regions of the state. Southern California, the Central Valley, the Bay Area, the greater Sacramento region, and then rural Northern California. We also were asked to put these together by our leadership to better understand the combined respiratory burden. So looking at flu and COVID together, and we've been doing that since February of last year. Again, we would like to add RSV into the mix. And part of this is because what is most policy relevant tends to be the burden on the healthcare system, not any one individual disease. And so for a long time, this was dominated by COVID. And so if you worked on COVID, you were sort of capturing the lion's share of the issue. Now it's starting to become more of a mix. And so last year and this past winter, we looked at COVID and flu together. And like I said, we'd like to add an RSV, but the data sources are not perfectly aligned in California. And RSV matters a lot for our pediatric space. And so, again, it's something that we want to work towards. But again, there's a lot of challenges which we can discuss if it's interesting to people. So I just want to show a couple what I call real-time modeling policy brief slides. And so, again, I'll be interested to hear everyone's backgrounds. I recognize some names on the call, others I don't recognize. But if you haven't really, I think some of you have worked with government public health agencies, but everyone is a little bit different. And so I was just going to show some slides that we'd shared up with our leadership over time, just to give a couple examples. So this was an interesting case of asking for one slide as kind of summarizing a lot of the early information on Omicron. You can see there's sort of a couple different things happening. This was probably December 2021, I think is the time frame. You can see here it's trying to compare Omicron and Delta, Moderna and Pfizer, looking at the effect of vaccination status for symptomatic disease and hospitalization, trying to summarize information there. We have some scenario modeling around varying assumptions around Omicron severity and transmissibility against hospital census. Again, we're not necessarily, we're interested in admissions, but really census is sort of a big metric that we care a lot about. And then here's a different scenario model from a different group, again, comparing sort of similar levers, but throwing in some contact rate changes and tripling the boosting rate. And so, again, sometimes we get asked for one slide that summarizes a lot of information. You sort of have to make judgment calls about what you include and what you don't include. Here's another one from later in that year. And so again, I think I'm hammering this point home, but a lot of what we really care about is overall hospital census, which is not easy to model, and there's not often data available to model it. But here we have sort of this two-parter. We're looking at the percent of our inpatients who are COVID positive. We're looking at sort of the reference census level compared with a baseline. And you can see this is the original BA1, BA2 Omicron wave. They were concerned about the second one that was sort of more of a swell than a surge. And we're able to articulate some patterns, and we're able to get some substate heterogeneity to share with our leadership. And so this is sort of examples of results that they found useful in thinking about their own policy making and communication and whatnot. So that's sort of the past. I'll talk a little bit about the present, and then maybe the future will be more for the discussion. So in terms of data sharing, we have a fairly extensive open data portal that's through the California Health and Human Services Agency. We provide a mirror of the CalCAT data, have provided COVID-19 cases, hospitalizations, and deaths. We had a very nice equity page, and we would share our equity metrics. The Scenario Modeling Hub US Scenario Modeling Hub is now using that information to do an equity round, looking at the pandemic retrospectively. We share a lot of wastewater data on this open data portal, et cetera, et cetera. We also have these DUAs, data use agreements, through the UC CDPH modeling consortium. I'll get back to that again, but you see in this case is the University of California. We have a number of campuses across the state, Berkeley, Los Angeles, San Francisco, et cetera. And, again, sort of one of the interesting implications of the end of the public health emergency last year was it impacted our ability to share data. And some of these agreements were struck in light of the state of emergency. And so we had to go back and rework them. And again, I would be sort of interested to hear if in the UK or elsewhere, if they had sort of similar situations where DUAs had to be extensively redone or basically rendered void by the end of some of these conditions, such as a public health emergency. We also embedded researchers internally at CDPH and in our modeling team for broader data access. And so this was, graduate students, postdocs, whatnot, and we were able to onboard them in such a way that they had fairly broad data access and were able to work on sort of special analytics projects. I also want to mention just, the enormous burden on personnel for data sharing within government agencies. And I think this is underappreciated, and I always mention it just so people are aware of it. If you ask for a new data source to be made available, but you're not providing personnel or positions to do so, it's really going to get backed up, and it's going to be a challenge because you're going to end up asking someone whose job it is not to do that to then take it on. And then you have to maintain pipelines. In some cases, you have to be careful about data suppression. And I've sort of seen this in real time on both sides of the coin. And I end up trying my best to support data sharing and data requests, but it does take time, frankly, and it's often not something that gets budgeted for. So I just bring that up as an important point. Our local and regional partnerships have really been key. And so, as I mentioned, we meet on a regular basis with our local health jurisdictions, our cities and counties in California, to share content with them, to get feedback, to consult with them about data issues. And so one thing I remember well is 2 winters ago, we had a pretty large RSV wave in California. The hospitalization data sources we had were not really picking this up, but we kept hearing from locals about the stresses putting on our pediatric bed capacity. And so it was some good insight we got from them. And I don't know that we ever sorted out what was happening in the data, other than it just wasn't a very useful marker of stress in the pediatric bed space, just because of the way things were reported and denominated. But it highlights, if you ingest data uncritically, you might miss a lot of sort of nuances that are happening. And so this is a space for us to try to hear about those kind of things and whatnot. We've also worked closely with Oregon and Washington throughout the COVID-19 pandemic, and also planned and co-hosted what we call the Western States Modeling Symposium in 2022 and 2023. And so this was states that were west of the Rocky Mountains. And we sort of tried to organize regionally around modeling capacity there and have had some success. Just a couple snapshots for interest. So we survey our CalCAT attendees. The CalCAT open house is what we call the meeting when we get together with local health jurisdictions. And we surveyed them over time. And so I'm just going to show a couple snapshots of what we've done. And so this was from spring 2022, so put it in context. But again, fairly informal surveys, but about half of them were checking CalCAT at least once a week. Some were checking a lot more, some were checking a lot less. Obviously, sort of a convenient sample of people who are going to be more likely to use CalCAT than not. But we do have a user base and we do talk to them. In terms of the local perspective, they tend to prefer the nowcast and the forecast and the more immediate results, whereas higher leadership tends to prefer more of the scenario models. So there's sort of that gradient, which is always interesting. So I think all that matters, but depending on where you sit, you might care more about nowcasting or you might care more about scenario modeling. So that was sort of an interesting insight from that survey. And then where does this get showed to? This is from last spring, but you can see by and large, a lot of it gets sort of percolated up to public health leadership, again, which is probably at the county and city level, somewhat at the state level. But then there's, various and sundry other stakeholders who the information gets sent to, depending on which health jurisdiction was talking about this. Our academic collaborations have been really key. I mentioned the UC CDPH modeling consortium, and this really helped us have closer collaboration with specific academic modeling groups. We've tended to find that California specific modelers tend to outperform on average sort of larger scope modelers who work at the national level. And I think some of that is just, if you're doing 50 states, you only have so much bandwidth and capacity to sort of hand tune and look at each of the 50 results. Whereas, if you're focusing on California, you have more capacity to do that. But I think it also allowed them to be in closer dialogue with us about what was happening with the data. And so as everyone knows, there's ways to sort of adjust for reporting delays and other sort of artifacts and issues with data, but being able to discuss it directly, I would assume had some benefits in terms of, being thoughtful about which model results they released and whatnot. We've also done some small grants through the consortium to fund some small priority modeling projects of interest to CDPH. We're currently in our second round of that now, and we had some really nice projects come out of the first round around school-based modeling and transmission in schools, some around equity and vaccination, et cetera, et cetera. We also use this space to cover other topics like the Mpox response and long COVID. And for those interested, a fair amount of the public meeting recordings and materials have been made available at this link, modelingconsortium.ucsf.edu. I also wanted to highlight that internal capacity building has been really key for our team and our organization. I think, we have sort of a slant at CDPH, which is that you really need capacity within government in order to function well in a partnership, and you can't outsource all the work. You will continue to work closely with academic institutions and other institutions, but you really need to have that capacity within your own public health department. And so to that end, we have worked on upskilling and collaborating more closely with subject matter experts. So that means people who work in informatics within the state government, people who are sort of the subject matter experts on particular diseases, and then working on staffing and growing our team to support this going forward. We work, again, try to have close contact with modeling groups that contribute to CalCAT. And we also work closely with our department and agency leadership, especially in the early days, to sort of increase model literacy, and so that they can understand what models mean, what the uncertainties are, what the pros and cons, and then get feedback from them to sort of further tailor modeling efforts and to think about how we can more effectively communicate and visualize modeling results. So let's see, I'll try to wrap up in maybe 5 minutes or so, but couple of specific things, some California specific challenges. We are a very large state. I've already referred to this, about 40 million people. And our counties range in population from about 1,000 to 10 million, so several orders of magnitude. Los Angeles County is 10 million and could be a state in its own right. And so we have a lot of different levels of capacity and a lot of different needs, and a real diversity from rural to urban and on various other sort of metrics and spectrums. So for us, our state level projections are less meaningful compared with smaller states. We're effectively a collection of several states, or could be several smaller states put into one. And so a lot of the national scale modeling groups do not make these county level projections. And so it's sort of up to us to foster and catalyze as much as possible groups that are working at the county and regional level. Our syndromic surveillance is also quite lagging, far behind other states. And so this is a map of NSSP. Some of you will recognize it and others won't, but California is sort of one of the weaker states, along with perhaps Colorado and Oklahoma, where we have a lot of counties and EDs not reporting data into the system. We're aware of it and we're trying to do something behind it, but it's an issue for us, especially if other sources of hospitalization data become unavailable. And then we're a home rule state. We're decentralized, so we have 61 local health jurisdictions, 58 counties, and 3 cities. And so in terms of decision making, we're working across the county to state to federal level. And so navigating a lot of different scales there. Some opportunities. We have a lot of technical expertise and talent in California, some really good universities. We have Silicon Valley that helped us, especially in the early days. We have pretty well-developed respiratory surveillance networks, which give us a lot of different data sets to work with, pretty extensive wastewater surveillance. And we also have mandated reporting separate from the federal processes. And so we're trying to figure out what that means going forward, especially in the case of NHSN. But there tends to be a preference towards alignment with what's happening at the federal level. And so we'll see what happens with that. And as I said, we're a very diverse state in a lot of ways. That's a real strength. And then because of our size, we tend to be relatively influential in policymaking. So I guess just to try to land the plane on a couple thoughts on tooling, I was sort of asked to reflect on tooling. So in terms of producing custom versus off-the-shelf tools and what we do, I think an important consideration in mind is you always have to be able to explain how the model or how the tool works, both to yourself and then to your leadership. If I present a result from whether it's EpiNow2 or EpiNowCast or another package, I have to really understand how it works, because I could be put on the spot. And if I can't explain that to the leadership person that I'm talking with, then there's going to be no trust, there's going to be no credibility. And so I think a first pass is you really have to understand how it works and be able to kind of generate trust in that tool to the people above you. Another thought is, what are your users actually using? And so Sam mentioned Julia before this call, but there's a lot of different coding languages, there's a lot of different visualization tools. And so on our team, we've tried to provide sort of an open source version of CalCAT for our counties to use. It turns out that not everybody is Shiny conversant, and they prefer Tableau or Power BI. And so we're sort of trying to figure out what that means for us as well. And then what is their coding modeling capacity? And again, that varies a lot by our local health jurisdiction. Do you need a no-code solution, a low-code solution, or something that's fairly modifiable and customizable? And I think that's a big question. And I think another underappreciated aspect of it all is how easy or hard is it to use with your health department's existing data flows? And so I've talked with several groups developing tools, and they may think you can just sort of plug it into your different data systems you're working, but the connecting piece tends to be a lot harder than I think people appreciate. And some of them is theoretically solvable with technology, but I think the reality of some of our public health data systems is just they're quite fragmented, and it's not an easy task. I'll just say that. So what we do personally is I would say what our team does is sort of custom tooling influenced by and/or using off-the-shelf modeling tools. And so I guess just in terms of like this group, we in a sense we'd like to use tools like Epi Nowcast, but there's hurdles for us. So CFA has produced some results using Epi Now 2 that's publicly available. And so people see that and they're like, well, why aren't you using Epi Now 2? And I say, well, there's this Epi Nowcast sort of project developing. And I know there's people more knowledgeable about the situation than me on this call, so I'd be interested to hear about that. But you have to think real carefully about what's put out in the public domain versus what's sort of happening more under the radar, because people are going to sort of develop their own opinions based on what they see themselves. There's the trade-off, of course, between complexity and explainability. And again, that sort of gets back to being able to explain what the model does or the tool does. And then how do we measure tool performance? And so this is an interesting sort of almost implementation science type question where it's like, well, what package should we use, and how do we measure its, how do we care about the trade-off between speed versus complexity versus accounting for this, delay distribution, et cetera, et cetera. So that's sort of an open question for me, is how do we really measure and think about tool performance? And then I'll just mention that on our team, Phoebe kind of leads our SAT-SCAN wrapper for cluster detection and visualization. And so this has always been an interesting conversation because government public health really loves SAT-SCAN. And a lot of academics who work on cluster detection really hate SAT-SCAN or disparage it. And so there's, I think, a real tension there. But frankly, it's what's getting used. It may not be what's you would call state of the art, but it's what people are using. And so should you push people to use something better? Well, then you got to make tools that are going to enable them to use it, especially people who may not have a ton of time to do a lot of coding. And so we have what I would call the need for two speeds. You really do need fast, simple tools to deal with quick turnaround asks and troubleshooting. And some scenarios I give for that is you need some report or some numbers on a certain timeline, but the source data processing is delayed. You need to reschedule your nowcasting process. Someone's staying up late at night to do this. They're waiting to hear the algo that the source data is clean, and it's 2 a.m. and you need the report by 6 a.m. You can't have a model that runs for 12 hours. It's just not tenable. And so you need some things that can work fast at the sacrifice of potentially some complexity. You may also have external stakeholders who are making these ad hoc requests that don't fit into existing pipelines. So you don't want to build out a whole new complex schema, but you want to be able to meet their need. And so you can do something fast, simple, and adequate. It's also good to have slow, complex tools to help with automated processes and long-term projects. So that's things like weekly processing, where maybe the outputs and timeline are not mission critical, or you have these really specific important modeling questions that benefit from using all the available data and background literature and accounting for some processes that may involve greater complexity. So to end, I'll sort of pitch these two open questions, which is, again, what is sort of the best model for academic government collaboration and public health response going forward? I thought of this as being more of a UK-based group, so I'd be interested to hear about the experience in the UK and elsewhere. It's something we're wrestling with in California. I know CDC is wrestling with it and other states are. And what does that look like to really be prepared for response in terms of setting the groundwork for academic government collaboration? And then an evergreen question is, how do we better align incentives across the community to encourage collaboration? Some people are endlessly caught up in the grant making cycle and grant winning cycle. Others have no interest in it. Some have to do reporting on a daily or weekly basis that takes up a lot of time. And so how do we get everybody, how do we align incentives for all these different groups? particularly when they're sort of prioritized in different directions. And then my personal question is, hearing from all of you in your respective spaces, what are the one or two things government public health could do to support progress in modeling? And I mean, funding is always an easy answer, but going beyond that, like, is it really data sharing? I've sort of highlighted data sharing, but are there sort of other interesting things that government public health could do to support progress in modeling? So I'll stop there for sake of discussion, but I'm always happy to talk with folks, share about our experience in California. We certainly don't have it all figured out, and we're trying to get better and trying to work with all of you in this space. So thanks for the time and look forward to hearing from all of you.
Yay, thank you, Tomas. That was really great. I personally took like 3 pages of notes. So super interesting. Could you maybe go back to your discussion questions slide just so we can like
Sure.
reflect on those? And I'm already seeing some hands, or they disappeared. Or maybe those were clapping. Anyway, I think that was really great. So I guess we can open it up for question. Sam has a question, but does anyone else have a question before Sam? If not, Sam can go. Okay, I'll let Sam
Okay,
go.
I'll ask one while other people save up. Something that struck me that I think has been reflected in other people's experience is your kind of observation that local groups, local modelers were really outperforming national and international groups on the same kind of question. I know Johannes Bracker is on the call, and in his nowcasting hub in Germany, his forecasting hub in Germany and Poland, the best performing model in Poland was like a really tuned agent-based model from a Polish group. And that's obviously not a model I would expect to do super well at forecasting, but because they had all the local context, it did really work really well. So my kind of question is, okay, that's great, but there are going to be groups and organizations and stuff that are not locally focused. And what can they do to best help your local findings if it's not because there's California, but there's all the other states, and then there's all the other countries, and there's all the other locations. Like, you can't do well at all of those things. What is it those kind of groups could do that would best help you or the people you're kind of collaborating with?
Yeah, that's a great question. I mean, I think the contextualization piece is really important. So I think even if they may not always be the number, and Lauren on our team sort of wrote a paper about this to even compare, like, well, is there one model that performs best for all California counties? And I think unsurprisingly, you'll hear, no, different counties had different top performing models, even if they weren't geographically co-situated and across varying periods, just like in other efforts, like performance sort of waxed and waned depending on, various factors. So there wasn't one model to rule them all. I think one advantage to sort of having groups, at least for us, model and do forecast or nowcast for, let's say, all 50 states, is it helps us think in context to what's happening with our neighbors. And so, when variant waves are happening, is like, okay, this variant has appeared first in New York or Washington or what have you, and how is that influencing trends and how is that being picked up in the consequent models? And so I think having sort of that common denominator or approach is really helpful, since we're always interested in what's happening with our neighbors. We're interested in what's happening in other countries. And so I think there's a lot of situational awareness benefit to going across states and countries and regions, frankly. And that it may not matter how those perform on a certain metric, but I think sort of the network and the contextual pieces of it are very helpful.
Okay, I'm gonna go to a question in the chat. This is from Nikos, who said, I find your comments on data sharing very interesting. Thank you. Would you say that overall data sharing practices have improved with the COVID-19 pandemic?
Yeah, this is one of those yes and no questions. I think, I think there's sort of been this fear that I'll just, again, all individual opinions. I don't represent the state of California or speak for it. But, I think there's a real conservatism in data sharing and a real concern that if we share too much data, then like all these horrible things could happen. And I think in COVID, we mostly learned that horrible things didn't happen and good things tended to happen when we shared data. So I think there was sort of some momentum generated around that. And so I think people are more open to it. I sort of alluded to sort of the end of sort of these emergency powers and sort of reverting back to the way things were done before. There are rules in place. I can only, again, speak at the California state level around what we can share. And so, for example, things like suppression and data de-identification are more strictly enforced. And so I think the granularity of data we can now share is not as good as it was in the early years of the pandemic. I think rule following has become more scrutinized. And so I think that's sort of an issue. That being said, we are working on some data use agreements to sort of not circumvent that, but provide another means for sharing sort of similar granularity data, but it's a long legal process. So I think I think people are more open to it, but I think sort of the rules again are more strictly enforced than they were a couple of years ago.
Right, cool. I'm going to ask the next question. So I loved hearing about what you're doing with the other states. I knew you had worked with Washington and Oregon before, but I don't think I knew that you did this Western States Modeling Symposium. Do you think that California's modeling team can serve as a model for potentially other states? And what more do you think y'all can do to kind of promote the growth of modeling teams that are at the state or local level throughout the country? Is it just, and what's the limiting factor here? Is it just about funding, or is it about, like, I don't know, more getting capacity building going or training? Like, is it personnel? There's just no one that wants to do it.
Yeah, it's so many things, but I think what I would call sort of a personal and maybe a community level disappointment for me is I'm not sure that we, and by we, I mean maybe US based, I don't know that I want to speak for other situations, but you all can reflect on that. I don't know that we made the case strongly enough for the benefit of modeling within government for public health, which is sort of a disappointment for me. I think a lot of people got value out of it. I think it was very beneficial for a lot of reasons. But when I talk to other states about them wanting to start modeling teams, I get sort of the response of like, well, what's the point? Like, why should we spend time on this? And to me, it's sort of self-evident, but to them, clearly we have not made the case. And so I talk to people who are theoretically leading modeling for their state, but can they consider it sort of lower tier importance? They say, well, we have to do all these other things. We have to do it tends to get lumped in with epidemiology. And so they say, well, we have to do this, that, and the other. And so I think what's the limiting factor? I think it's making the case for the benefit of modeling within these government institutions. Some of it has to do with funding. A lot of these positions have, the salaries are not competitive. And so that's going to be sort of an ever-present issue. But, I think maybe the thing that needs to be done is to make the case for like, well, what can modeling teams do for you? What can modeler statisticians, how can they help your department? And the problem is these departments get saddled with so much ongoing responsibility that they can't just give away or take off. And so, one sort of case I've thought about making is, well, these people who are modelers tend to be pretty good coders, programmers, automators, whatnot. Like, could you help automate epidemiological processes? And in doing so, free up time to work on sort of analytics projects and modeling projects. Like, do we have to make the case in some other way to free up time for people to work on forecasting, nowcasting, whatnot? So that's sort of where my head is going. I think a lot of states are interested, but not a lot of states can solve the funding problem and or have interest in actually doing so. That's sort of been my experience.
Okay, that's super interesting. I wonder if there's a way to hop on the bandwagon of an existing association, like, CSDE, for example, is a really strong group of epidemiologists that meet. It's, for those who are not US based, it's like the something for state and territorial epidemiologists, and every year they have this big conference. So in the way that I feel like we've started to infiltrate ASTMH, maybe we can start infiltrating CSDE, just like one or two modeling presentations, and then we get people used to it. And then we have more opportunity to show the value. I
Yeah,
tried to
and
go to CST the other year, but they said I couldn't go. So I tried. We have to keep
I
submitting
think just
abstracts.
yeah, a quick comment on that is just that yeah, I believe it's the Council of State and Territorial Epidemiologists. They
Council, yes.
they're they're doing a lot of work in this area, and so I wanna really trumpet them for that and trying to do some of these peer-to-peer connections and help generate funding opportunities in a network. I think at the end of the day, the states themselves have to do it, and the cities and the counties, and so you can what is it? You can lead the horse to the water, but it's sort of up to them to to drink from it. And I think they're facilitating that, but I think there have to be other actors in that space too.
Okay, Seb, do you want to go next?
Yes, thank you for this very insightful and interesting talk. I was curious about your comment that kind of, there's these things that you need to balance, like speed and efficiency and performance and accuracy and whatever. And I get that. And then you mentioned that CFA used something else, but you made a different decision. And it made me wonder, do you ever like exchange with other public health agencies on why you made those decisions? And is there anything others can learn from you or you can learn from them, or do these things happen in isolation? It just makes me wonder why different agencies choose to do different things or choose to implement their own thing, but then not share it with other agencies, perhaps, or I don't know, but perhaps there's just not that much communication. But how is that working out for you?
Yeah, it's a great question. Yeah, I guess to pull the curtain back further, I think there is a lot of communication. I think, these are all large bureaucratic organizations. And so at various times I talk to CDC and then to CFA within CDC about some of these issues. And, in most cases, especially for them, when they're a larger organization than ours, the data provisioning and the people running the data pipelines may be different people. Whereas as you get to smaller agencies, California is still pretty big, your data and your modeler person might be the same person. And so it's a very tight loop. And in other organizations, there's whole separate processes for data processing and whatnot. And then the modelers may sit somewhere else. So I think there is a triangulation or a pentagonation. I don't know how a lot of people involved. In terms of like what stakeholders do, some of it is just, I sort of alluded to it, like our available data is just different. And so in the US, a lot of groups are thinking about using RESPNet data. There is RESPNet presence in California. It's specific 3 counties that are representative of a region, but not of our state. And so whereas they might prefer to use that as sort of representative of California, for us, it's not quite the same thing. And so we might choose to have a different approach and use a different data set that may not be available in other states. And it's therefore harder to organize like a modeling effort since California wants to use a bespoke data set that other states don't produce or produce in some of their form or fashion. Some of it also just gets baked into like historical decisions. And so certain states might have tied up early on with certain academic institutions, and they sort of drove the agenda for the modeling decisions. And so it may be like external actors who are making the decisions for certain agencies or strongly influencing it. And so if you're a state and most of your modeling is being done by a university or a research think tank, that's sort of like a different level of decision making than what's happening at maybe the state epidemiologist level or within the public health infrastructure. So there is some communication. There definitely should always be more. And I know there's groups like, again, CST, CFA, and others who are trying to facilitate some of those dialogues. But yeah, there's still a lot of work to do.
Thanks.
Great. Okay, Sam, do you want to go next?
Sure. Or shall I read out Nikos's follow-up question?
Yeah, let's do that first.
Oh, okay. Okay. So Nikos in the chat asks, in your opinion, is that more a communication problem, or is it that a problem related to the inherent limitations of modeling? And that's in reference to the case for modeling.
Yeah, it's a good question. Probably both. I mean, I think some people on the call have actually written the papers about sort of model performance and like the limitations with, let's just say forecasting for now in terms of like the time horizon and how reliable it is. And so I think uncertainty is always hard to communicate, and people who tend to deal in absolutes or have to make specific decisions and then justify them to their constituents. Uncertainty is just really hard to communicate, and it tends not to be popular with a certain part of the population. So I don't know that I think there's a lot of people trying to do this really smartly, and I think of a lot of work in this area, and I think that's great. I think at the end of the day, uncertainty is just a hard thing to communicate. That's just the reality. And so related to the inherent limitations of modeling, I think some actors oversold what modeling can do early on in the pandemic, and that sort of poisoned the well in some cases. And so when you couldn't predict the future, not that anyone said they could predict the future, but that was sort of the message that people took away from it. And then when they couldn't do that, that sort of hurt credibility. And I think probably many people on this call are familiar with that.
All right, Sam, do you want to ask your question now?
Yeah, sure. So I actually have some feedback for the what could government public health do, and then I have a question.
Great.
So my feedback is the number one thing that I always want is a public statement somewhere of any kind if government public health is using something and they like it, because that is really useful in all sorts of like applications and things. And it's really surprisingly hard to come by. So I don't know what that looks like, but that would be amazing. The other thing is more active involvement from people using the tools, so in government public health and whatever, in developing them. Because there's sometimes this kind of conception that there's a vending model where they're kind of like academic collaborators are over here and they're developing stuff, and then the people who need it, they come in and they use it, and then it doesn't quite work in the way they want, so they drop it and they try another one, or they roll their own. And that, I think, is because it's really hard to guess what everyone's needs are. And even when you're collaborating with them, that can be a really slow process. So something I found much more valuable is to like have collaborators who are actually working on tasks, and for them to help you improve the like small areas of a tool that are pain points for them. And then over time, you end up getting a tool that's kind of like better for everyone. And that I found in practice very hard to make happen because everyone has so much work to do and kind of like time horizons and stuff. But I think just kind of like more awareness, maybe, that if you spend a little bit of time developing on a tool, you will be a much better user of a tool. And so it's valuable to set aside some time to do that sort of work, even if it's just like fixing typos in documentation and stuff, because then when you need to use it, you'll have a much better grasp of how the tool works. That's my kind of like sales pitch for why contributions are good. Yeah, but my question was, you mentioned that you needed to sell tools to stakeholders and kind of justify why we're using this, why we're using that. And I wondered if there was something that tools could be doing that would be useful to help you with that. Because like often tool documentation and stuff is written for like a user or for like a technical colleague. And we don't often write kind of like essentially the stakeholder summary. Would that be useful? And the model I'm kind of thinking of a bit here is the CFA have been putting out these technical blogs. I don't know if anyone's seen them, but they're kind of like a high level summary of how things work. Is that sort of thing helpful or something else? I'll find one for everyone else.
Yeah. Yeah, super interesting. Thank you. So first, to respond to your feedback, I'll just say, and I put sort of our shared inbox in the chat, but I mean, I would encourage tool developers to feel free to directly reach out and let people know it exists. Like, I think one thing is I try to keep my ear to the ground as much as possible about new developments, but it's just not possible to keep up with everything. And so, I sort of invite whoever on this call is interested to share with us and share with others, to sell your tool to us, so to speak. Like, why should we use it? And, that's probably a large part of it's us not engaging. We just may not know. It may be two things. It may be we don't know it exists, or it may be just a time issue. So I think we're certainly open to that. We have written a lot of letters of support for various people. So I mean, I think if you have a grant coming up that you're submitting for and you want us to use it, you can always pitch that. And we've sort of been able to partner with different groups on that piece of it, even without funding. We're happy to sort of give feedback, but again, it does take people's time. So to your question, I think the technical blogs are really great. I think it's sort of like maybe halfway there to what I'm talking about. Like, I think that's meeting a lot of users' needs, but what I'd love is something like even more concise, you know, so sort of like a short narrative form and like on the order of a paragraph or two to really like walk through like, what's this doing and how is it different or not different from other nowcasting or forecasting or whatnot tools. So I think the technical blogs are like a real great step in that direction. But yeah, I think I said, yeah, like a one pager or shorter. I think either of those options are really good. But yeah, that would help us sort of sell it and then also help us in our own sort of narrative, sort of digesting what's happening.
Cool. All right. Are there any more questions for Tomás? No. Overall, this was a really great walk through what you guys are doing. I'm really excited about it and hope to see more from California soon. So again, thanks, Tomás. We'll be back next month with Emily Pollock from CFA. Don't know what she's talking about, but I'm sure it'll be super interesting. So you should come back for that, and we'll try to advertise sooner. So Sam and I will get on that. So after this call, Sam, stay on so we can walk through that. But yeah, thanks again, Tomás. I appreciate you getting up early.